Okay. Um, well, ladies and gentlemen, dear colleagues in SciMag and in the Japanese Seculiac Joint Research Group, thank you very much for inviting me here. During my whole medical career, I have elaborated on techniques to understand buttock pain. It's my disclosures. My name is Bengt Sturesson. I am working at the spine unit at the hospital in Ängelholm, located in the south of Sweden. I have been studying the sacroiliac joint for almost 40 years and performed sacroiliac fusions since 1989. I started with minimal invasive surgery 2011. Until now, I have performed about 600 surgeries. When challenging the problem as a medical student, pain from the buttock area between the spine and the hip could be described as a white spot when asking professors and orthopedic surgeons. I had a very fantastic professor at the orthopedic department in Malmö. He made it possible for me to do research on the white spot. The uttermost problem and my challenge was, what tools should I use to differentiate the pain from the sacroiliac joint from lumbar or myofascial pain? For the diagnostic procedures, knowledge of anatomy and biomechanics is imperative. The function we expect from the sacroiliac joint is to transfer load from the spine to each leg. But as an orthopedic surgeon, I had a problem. I started my research to measure movement in the sacroiliac joints, but what to do with my patients in pain? They had no effect only of the measurements. And I will talk about biomechanics later today. Movements in the sacroiliac joint were too small to detect a clinical examination. To defend surgery of the sacroiliac joint, we decided to use the Hoffman lattice frame as a diagnostic tool and at the same time measure the effect of the sacroiliac joint movements. The effect was miraculous to many patients. The external fixator improved the function and reduced pain. Biomechanically, compression of the frame reduced the movements in the sacroiliac joint. And this was my first diagnostic tool. These results really was a game changer, understanding the biomechanics of the sacroiliac joint. The effect of the external fixator raised the issue to discuss stability instead of instability in the diagnostic process. The opposite is individuals with non-optimal joint stability. The inability to stabilize the joint is in most cases due to a painful degenerated joint. I will show you a patient where we used the external fixator as a diagnostic test. This is one of my favorite slides. This is a patient with non-optimal sacroiliac joint stability. To the left, without frame, and to the right with. Just look at the difference in walking speed. It is the same patient. On the left side, after 6 weeks of specialized physiotherapy. On the right side, 2 weeks after the test surgery with the application of an external fixator. External fixator is a difference between inability and ability to load the leg. So I operated my first patient in 1989. We used the external fixator as a preoperative tool for 3 weeks, and if they have a good success, we operated on them with the Smith-Peterson technique, and the postoperative stabilization with the external fixator for about 4 months. But after starting with minimal invasive surgery, I had to change my diagnostic process because to use a maximal invasive diagnostic procedure and minimal surgery, it was not a good way of doing the process. So we did a pilot study for minimal invasive sacroiliac fusion. In that study, we used the iliosacral screw as a last diagnostic procedure instead of external fixator. However, with only 1 out of 26 patients refused thoracic fusion with this screw, we concluded that this is a too big procedure, and maybe it was also overdue to do this sacroiliac joint screw fixation. So we created a new diagnostic algorithm. Patients with pain from the sacroiliac joint often has a specific history. Previous trauma to the pelvis without fracture, long-standing pain post-pregnancy, and degenerative spine problem. The pain has to be located below the L5, and the pain drawing is very helpful. Patients with sacroiliac pain suffer pain in all different types of load: standing, walking, sitting, and also lying on the supine position. Most patients sleep in a flexed side position. With the clinical examination and MRI, we exclude the lumbar spine and the hip joint as pain sources. The diagnostic sacroiliac joint procedures, according to the European guidelines, is what we use. And I will show you here the Østgaard test. And that is well studied, and the force put in the direction of the femur has to be gentle. A force of 50 Newton is enough. The Thabert test, flexion, abduction, external rotation. And the pain is typically coming with a reduced ability to abduct. Lateral compression of the pelvic wings. The pain has to be experienced in the sacroiliac joint area and not where the examiner put the pressure. And the Gensler's test, it's amazing. It's described already in 1927. And palpation for a painful long ligament. This is a sensitive test and a sensitive area located close to the sacroiliac joint. The active straight leg raise is a functional test. I will show you the effect of the function later. And then we added the load transfer test, and that reveals the ability to transfer load from the spine to the leg. In this study from the Kansas University and Texas Beck Institute, they showed the standing balance before to the left and 6 months after surgery. After the positive testing, we confirm the diagnosis with a sacroiliac block. And from my point of view, the joint can, in most cases, be easily reached in the inferior part of the joint. A small amount of contrast confirm the needle position, and about 2 milliliters of local anesthetics injected in the sacroiliac joint. Here, we ask the patient to lift first the right, not painful side. And on the left side, you can see how difficult it is to raise the leg. Then we do the block. After the block, we ask her again to lift first the right leg. When lifting the left leg, the patient surprisingly lifted the leg higher than she was asked, and the active straight leg turns to normal, and the sacroiliac block restores the muscle control. With the load transfer test, we check the ability of the patient to take load on the leg before and after the sacroiliac block. This is a movie. The patient makes 2 attempts to stabilize on the left leg before the block. So, with the local anesthetics in the sacroiliac joint, we can restore the muscle control, improve the balance, and the ability to load the leg. Quite a dramatic effect of the block. So, the external fixator and the internal screw fixation was excellent diagnostic tools, reducing the movements and restoring function. But a sacroiliac intra-articular block is less invasive, and can correctly performed according to my experience be recommended as a diagnostic tool, identifying the sacroiliac joint as the pain source. Diagnostic block is positive if the pain is reduced by 50% and diagnostic test returns to negative. And the function of an active straight leg raise and load transfer test is restored. Thank you very much. Arigato.
Thank you very much for great presentation. So I have a question. So you use the external pelvic fixator. So I would like to ask you. So did you do something after the fix? Put the device. So for example, compression or rotation to control the pain of the patient.
Well, it is very exciting because I started to use that in 1989 and during the 90s. And at that time, we didn't know so much how to diagnose the sacroiliac joint. And I stopped the movement. I proved that I stopped the movement with the external fixator. And the patient, they were able to walk. And I did the operation on them. I sent them home for 3 weeks. And then they returned after 3 weeks. If it still was no pain, I did the surgery. And I didn't, at that time, we challenged to find what test should we have. It was really the early steps, 1989, 1990, 1995. It was before we know more about this. So I didn't use that. And I stopped to use external fixator 2010 was my last patient with external fixator, because then we start with the minimal invasives, and then that was why we started to do the better algorithm for the diagnosis. And we actually worked very hard to find out what tests can we use. So I, in the past, I had no test because I couldn't do it. I didn't know.
Thank you very much. So you mean that you didn't no procedure after put the fixator. So I imagine that you did compressed the joint or loaded the joint.
Yes. Well, that's also a very interesting thing. But how to use it? The external fixator was used previously by a Finnish surgeon, Per Slätis, who invented it for fracture treatment, and he actually used it also in patients with pelvic girdle pain. But he didn't know what he did. And when I put the fixator on, yes, I compressed. So that, and I also tried different techniques. It's like first step you do, but I put it on. I did the surgery and put it on, and then I raised the patient, and then it was painful. So then I compressed. When they stand up, I could compress it, and then what happened? And I measured that as well. That the sacrum rotated anteriorly when I compressed. So it came to a better, more stable situation. We know now that if you have anterior rotation, then you compress. And I will come back to that with the biomechanics in the afternoon as well, because it's quite interesting to see what is the biology, what is the biomechanics of a sacroiliac joint. But the compression puts it into a stable position.
Thank you very much.
Thank you for excellent presentation and lecture. And I have a question. So this picture shows so many young women. So I think there is some difference between the number between male and female about the sacral joint pain or something.
Well, it is also interesting. It is young women, because most of my patients came from patients after pregnancy. And if you're a young woman and not able to walk, to sit, to have sex, then you get depressed and you don't know what to do in the life. And you see the after surgery, they look quite happy, and that is one of my missions, to make young women happy. But men also get pain in the sacroiliac joints, and I operate about 10% of my patients are men. And it's degenerative spine. It is early ankylosing spondylitis, because in the early ankylosing spondylitis, no tests are positive for blood tests and so on. So I can put their, length of pain, reduce it to half a year instead of 5 years, because that is a normal course of ankylosing spondylitis healing. And also, for example, psoriatic pain in the joints. So 10% of men, and they are usually older. They are usually, well, my youngest man, he was 21, but the oldest man I have operated on, I think he was something like very old, 60, something like that.
Thank you very much.
When you did the external fixators, was there also a surgical approach for an anterior approach to the SI joint, or the only thing you did was place the fixator?
Oh, well, for the diagnostic, I put the external fixator. And then, if they were positive, after 3 weeks, I did the posterior or lateral fusion with the Smith-Peterson technique. I didn't remove I did take away the fixator, but I didn't remove the screws.
Okay.
Yeah.
At the beginning, when you had a picture of a compression screw, and the patient didn't do well.
Yeah.
And so you stopped doing that.
Yeah.
So can you explain why you think they didn't? Because I am a very big believer with compression. That's and I think it's critical.
Yeah.
What is your explanation on why that didn't work?
It was the wrong diagnosis.
Okay.
It was because the problem is in the gluteal area. Mm-hmm. You have a lot of diagnoses. We have heard that if you do blocks in the ligaments, there's a lot of different pain. Mm-hmm. So it was most likely not intra-articular problem.
Okay.
Yeah.
That helps me a lot. I thought you were telling me I was doing it wrong.
I only operate on intra-articular problems because that is what I can defend.
Yes, absolutely. Yes. Thank you.
Thank you for a great lecture. So I'm Dr. Kaneuji. And I ask you, do you use intra-articular block every time?
Yes.
So yeah, Dr. Murakami said to the ligament blocks. So.
Yeah. And the case is, Sweden is a little quite difficult in this topic. You need, if you want to do a sacroiliac fusion, then you need to do an intra-articular block, because there should be something wrong in the joint, and if you have the problem around the joint, you're not sure that you will have the problem that you solve the problem with the fusion, because it is extra-articular problem, and I think it's very important to, if you want to do a surgery, you do need to have an intra-articular block and rely on that. And today in my clinic, I will talk about that later. So I have every week a clinic for pelvic, and I see 3 patients. I do the examination, me, my physio, and we do the block, and then we re-examine the patient after that. And out of 3 patients, maybe we find 1 that is positive, and they are selected from the beginning as well. So it's so important. If you want to do surgery, you have to be very, very strong with the selective process.
Okay, thank you.
So I have a last question. So I know. So you have a good skill to do the intra-articular sacroiliac joint injection. I know. So, but if the patient have a bone spur or a partial fusion of the joint, so it may be difficult to do successfully for intra-articular injection. If you fail the intra-articular SRG injection, you will not do the SRG fusion surgery, right?
Yes.
Mm-hmm.
Yeah, well, they had to have the positive effect of a block. If not, sometimes I had done, I don't know, 2,000, 3,000 sacroiliac blocks. Mm-hmm. So it's because I did 650 surgeries, and a lot of them don't go to surgery. So it's so many. So if I miss, and I think I missed it, I take the patient back and I do it again, because sometimes it can be a doctor's failure. You have to be so humble to realize that you're not perfect every time. but actually it is maybe 95% I always success with the block.
So can we diagnose sacroiliac joint pain instead of using the pelvic external fixator instead of injection if we fail the intra-articular injection?
Oh, well,
what do you think?
Today it's impossible to do that procedure because patients
too
know,
invasive.
the patients know so much, but actually the patients sometimes they come to me and say, "Oh, I don't need the external fixator." Fantastic. So there's rumors and so on. But of course it's possible to use if you have a problem. Yes, and it happens, but not many years ago. But I did it, but not anymore. Honestly.
Thank you very much.
Okay.
Any other questions? Okay, thank you very much,
Thank you.
Dr. Sturesson. Thank you.